Chapter 23. Contrast Media and Introduction to Radiopharmaceuticals. Key terms. Acid group. Contains carbon double bonded to an oxygen, single bonded to another oxygen, and a negative charge at the pH of the body. Amine group. Contains nitrogen bonded to two hydrogen atoms. Anaphylactoid. Resembling an immune system response to foreign material, antigen. Atomic numbers. Numbers of protons in the nuclei of the different elements. Blood urea nitrogen, BUN. BUN test can reveal whether the urea nitrogen levels are higher than normal, suggesting that the kidneys or liver may not be working properly. Bond. Interactions between electrons of atoms that hold the atoms together in a stable group. Line drawn between atoms indicates a bond such as H-O-H. Bronchospasm. Involuntary constriction of the bronchial tubes, usually resulting from an immune system reaction to a foreign particle or molecule. Compound. A substance composed of two or more elements combined in definite ratios that give the substance specific properties. Contraindications. Factors of a patient's history or present status that indicate that a medical procedure should not be performed or that a medication should not be given. Creatinine. Nitrogen-containing waste products of metabolism excreted by the kidney's filtration system. High blood plasma levels indicate poor filtration by the kidney. Dimer. Compound formed by bonding of two identical simpler molecules. Extravasation. Leakage from a vessel into the tissue. Flocculation. Formation of flaky masses resulting from precipitation or coming out of a suspension or solution. Histamine. Molecular substance containing an amine group, causes bronchial constriction and a decrease in blood pressure. Hydroxyl. Common chemical group, part of the water molecule, containing one atom of hydrogen and one atom of oxygen, carries a negative charge, anion, when not a part of a molecule. Ionic. Atom or molecule having a negative charge, anion, or positive charge, cation. Methyl groups. Common biochemical groups containing one carbon atom and three hydrogen atoms. Molecules. Stable groups of bonded atoms having specific chemical properties. Monomers. Simple molecules of a compound of relatively low molecular weight. Osmolality. Measurement of the number of particles, molecules or ions or cations, that can crowd out water molecules in a measured mass, kilogram, of water. Osmosis. Movement of water from an area of high concentration to an area of low concentration through a semi-permeable membrane such as blood vessel walls and cell membranes. pH. Relative acidity or basicity, alkalinity, of a solution. pH below 7.0 is acidic and has more hydrogen cations than hydroxyl anions, whereas pH above 7.0 is alkaline and has more hydroxyl anions than hydrogen cations. Radiopharmaceutical. Pharmaceutical compound that is attached to a radioisotope. Shock. Inadequate blood flow within the body with resulting loss of oxygen and therefore energy. Solution. Uniform mixture of two or more substances composed of molecule-sized particles that do not react together chemically. Suspension. Non-uniform mixture of two or more substances, one of which is composed of larger than molecule-size particles that have a tendency to cluster together. Ultrasound contrast agents, UCA. Exogenous substances that can be administered to a patient to enhance ultrasonic signals. These can be administered either in the blood pool or in a cavity of the body. Introduction to contrast media. Historical aspects of contrast agents. Air, a negative contrast medium, was initially used in 1918 by Walter Dandy, a neurosurgeon who did injections of air to study the cerebral ventricles of children with hydrocephalus. Dandy's published articles initiated the use of air to localize tumors within the brain and spinal cord. Later, carbon dioxide, nitrous oxide, and oxygen came into use. Immediately after Röntgen's discovery of X-rays, physiologists realized that the functions of the digestive system could be monitored by giving animals food mixed with compounds of high atomic number and watching the mixture's passage by way of a fluorescent screen. In 1896, lead subacetate was used to study the digestive system of the guinea pig. However, it later proved to be toxic. In the same year, Walter Cannon, then a Harvard medical student, began a series of experiments to study the digestive system using bismuth subnitrate. His subjects included geese, cats, and a 7-year-old girl. Although bismuth subnitrate eventually proved to be toxic, Cannon is credited with awakening the medical profession to the realization that diseases of the gastrointestinal, GI, tract could be studied by watching the movement of radiopaque media through the tract. Toxicity remained a problem with many of the compounds with high atomic numbers in those early years. In fact, thurotrast, which incorporated thorium, proved to be radioactive. By 1910, articles about the advantages of the inert and insoluble compound barium sulfate began to appear in medical literature. Its use increased rapidly because of its lack of toxicity, low cost, and availability. Water-soluble iodinated contrast media were introduced by Agos Moniz in 1927 when he injected sodium iodide into the cerebrovascular circulation by way of the carotid arteries. Sodium iodide proved to be a blood vessel irritant. During the 1930s, chemical methods improved. Atoms with high atomic numbers, such as iodine, could be placed on non-toxic water-soluble carrier molecules. Eventually, more iodine atoms per molecule were added, which increased visualization of the vascular and urinary systems. The 1950s saw the beginning of the use of 3 iodine atoms per carrier molecule. These triiodinated molecules are the basic chemical structures from which both ionic and non-ionic water-soluble iodine contrast media originate. Ultrasound contrast agents, UCAs, have been in development since 1968 and have been utilized in Asia and Europe for decades with excellent safety profiles and efficacy. Contrast-enhanced ultrasound, CEUS, has gained more widespread use in the United States after the FDA approved their use to characterize liver lesions and diagnose vesicoureteral reflux in 2016. Purpose of contrast media. For anatomic detail to be visualized, the area of interest must differ in radiographic density from its surrounding tissues. The ability to distinguish between radiographic densities enables differences in anatomic tissues to be visualized. Factors that affect the degree of radiographic density differences include absorption characteristics of the tissues that comprise the anatomic part, technical factors used, characteristics of the image receptor, automatic image processing, and the use of contrast media agents. The body absorbs X-ray photons according to the various tissue atomic numbers and the amount of matter per volume of tissue. Tissues with higher atomic numbers absorb more X-ray photons than those with low atomic numbers. For example, increased absorption of X-ray photons occurs with bone because calcium has a high atomic number, whereas soft tissues transmit or scatter X-ray photons more easily, resulting in decreased X-ray absorption. Radiographic images of anatomic areas classified as low in subject contrast result in few density differences and are difficult to visualize. Instilling a contrast medium into the area of interest will change the absorption characteristics of the anatomic area and alter its subject contrast and the radiographic density differences. Enhancing the density differences within the area of interest will improve visualization of the anatomic detail. For ultrasound, UCAs increase the backscattered signal intensity. This, in turn, improves blood flow analysis and enhances the grayscale structures using contrast media are diagnostic agents that are instilled into body orifices or injected into the vascular system, joints, and ducts to enhance subject contrast in anatomic areas where low subject contrast exists. Essentially, contrast media is utilized to visualize anatomic structures that are not usually evident on a diagnostic medical image. The ability of the contrast media used in radiographic procedures to enhance subject contrast depends greatly on the atomic number of the element used in a particular medium and the concentration of atoms of the element per volume of the medium. The ability of the contrast media used in ultrasound procedures to enhance subject contrast depends on the mechanical index of the sound beam and the contrast agent being used. Contrast media are generally classified as negative or positive contrast agents and ionic or non-ionic contrast agents. Negative contrast agents used in radiography decrease attenuation of the X-ray beam and produce areas of increased density on the radiograph, whereas positive contrast agents increase the attenuation of the X-ray beam and produce areas of decreased density on the radiograph. UCAs are classified as first or second generation agents depending on the gas within the microbubbles. First generation UCAs utilize a high mechanical index resulting in early destruction of the microbubbles, while second generation UCAs utilize a lower mechanical index allowing for longer exposure times without microbubble destruction. General types of contrast agents. Radiolucent, negative. X-ray photons are easily transmitted or scattered through radiolucent contrast media. As the name implies, these media are relatively lucent to X-rays. Because the anatomic areas filled by these agents appear dark, increased density, on radiographs, they are also called negative contrast agents. These media are composed of elements with low atomic numbers. Radiopaque, positive. X-ray photons are absorbed by radiopaque contrast media because these media are opaque to X-rays. Because the anatomic areas filled by these agents appear light, decreased density, on radiographs, they are also called positive contrast agents. These media are composed of elements with high atomic numbers. In some instances, negative and positive agents are used together so that the lumen of organs, such as the colon, Fig 23.1, can be visualized, or so that anatomic structures within a space, such as the menisci of the knee, can be visualized. MRI contrast agents. Contrast agents of varying types are also being used in other modalities. A common intravenous contrast agent used in MRI studies is gadolinium diethylenetriamine pentacetic acid, gadolinium DTPA. This contrast agent is a metallic and magnetic agent that will affect the signal intensity used to image the anatomic area of interest. MRI contrast agents can be classified as negative, i.e., diamagnetic contrast agents, and positive, i.e., paramagnetic contrast agents, similarly to that of radiography contrast agents. Ultrasound contrast agents. Physical properties. Ultrasound contrast agents are composed of gas-filled microbubbles with a phospholipid shell. These microbubbles are administered intravenously or instilled into hollow structures like the uterus or urinary bladder. These agents have a purpose similar to that of radiographic contrast agents, that is, of enhancing the subject contrast of the area of interest. Specific procedures. UCAs can provide detailed blood flow characteristics of a neoplasm, such as arterial phase hyperenhancement and venous washout. This provides a more accurate diagnosis and more effective treatment plan. UCAs are also commonly used to perform a contrast-enhanced voiding urosonogram to diagnose vesicoureteral reflux and to better define the borders of organs and neoplasms. UCAs have also several off-label uses, such as assessing for endoleaks after an aneurysm repair, bowel wall inflammation in Crohn's disease, assisting in ablative procedures, with similar results to CT and MRI-guided ablations, and targeted drug delivery. Adverse reactions. Because UCAs are composed of lipoproteins shells that are metabolized by the liver and air that is expelled through the lungs, they are considered non-nephrotoxic and safe. UCAs demonstrate very similar or much lower adverse reactions than CT and MRI contrast agents. Negative contrast media. Physical properties. Negative contrast media are composed of low atomic number elements and are administered as gas, air, or gas-producing tablets, crystals, or soda water, carbon dioxide. Because cells absorb oxygen quickly, this gas is rarely used alone as a contrast agent. Specific procedures. Air alone provides negative contrast for laryngopharyngography because upper respiratory tract structures contain air naturally. Otherwise, radiolucent contrast media are used in combination with radiopaque media to outline the lumens of, or spaces within, body structures. Common double contrast studies, area to be imaged, contrast agent, method of administration, patient preparation, and patient instructions and care during procedure. Stomach, barium sulfate, administered carbon dioxide in tablets, crystals, or soda water. Administered orally. Nothing to eat or drink after midnight before examination. Patient should not belch after carbon dioxide is given so that the lumen of the stomach can be seen. Large intestine, barium sulfate, and air, administered rectally. Patient to drink large amount of fluid before examination or consume a fluid diet, and nothing to eat or drink after midnight before examination. Cleansing enema prior to examination. Provide supportive communication so that the patient does not lose control. Arthrography, imaging of the shoulder, knee, wrist, or hip. Administer a water-soluble iodine media and air injected into joint space. No patient preparation is required. Provide supportive communication because stress views performed during procedure can be painful. Adverse reactions. Generally, complications from the administration of negative contrast agents are minimal, although air can cause emboli. These small air masses can enter the circulatory system and become lodged in blood vessels, causing pain and loss of oxygen to the area. Patients who receive barium sulfate with air should be instructed to drink plenty of fluids after the procedure to dilute and eliminate the barium sulfate. Administration of water-soluble iodine contrast media along with air in the joint spaces usually does not result in complications. Positive contrast media. Barium sulfate contrast media. Physical properties. The element barium has an atomic number of 56, thus, it is radiopaque. Barium sulfate is an inert powder composed of crystals that is used for examining the digestive system. The chemical formula is BaSO4, which indicates a ratio of 1 atom of barium to 1 atom of sulfur to 4 atoms of oxygen, thus, it is a compound. Because barium sulfate is not soluble in water, it must be mixed or shaken into a suspension in water. Depending on the environment of the barium sulfate, such as acid within the stomach, the powder has a tendency to clump and come out of suspension. This action is called flocculation. Stabilizing agents such as sodium carbonate or sodium citrate are usually used to prevent flocculation. These ingredients are listed as suspending agents on the container labels. Other ingredients used in orally administered barium sulfate include vegetable gums, flavoring, and sweeteners to increase palatability. Barium sulfate suspensions must be concentrated enough that X-rays are absorbed. These suspensions must flow easily and yet coat the lining of organs. For studies of the small intestine, oral formulations of barium sulfate and methylcellulose, a non-digestible starch, have been introduced. These preparations are designed to give a see-through effect to better diagnose small lesions. For lower GI studies, general recommendations are that barium sulfate be mixed with cold tap water to reduce irritation to the colon and to aid the patient in holding the enema during the examination. Cold tap water reduces spasm and cramping, although mixing the barium sulfate with room temperature water has also been recommended for maximal patient comfort. A primary function of the colon is to absorb water from waste. However, increased water absorption by the colon can result in excess fluid entering the circulatory system, hypervolemia, a serious, sometimes fatal, complication. The addition of 2 teaspoons of table salt per liter of water used in the enema preparation reduces the risk for hypervolemia. Following the manufacturer's directions is critical when mixing barium sulfate suspensions so that diagnostic radiographs will be obtained. Specific procedures. The administration of barium sulfate can result in complications, generally as a result of pre-existing patient disease or status. If a patient is thought to have a perforation in the digestive tract, barium sulfate is contraindicated because the body does not absorb barium sulfate naturally. If it enters the peritoneal or pelvic cavity, barium sulfate can cause peritonitis and must be surgically removed. In place of barium sulfate, a water-soluble iodine contrast agent is recommended. The body is capable of absorbing this type of agent. In certain patients, the administration of barium sulfate can result in traumas such as perforation of the colon or vaginal rupture due to incorrect catheter placement during a barium enema study. Aspiration in the bronchial tree, constipation, barolith, and obstruction are also examples of potential complications from barium administration. The radiologic and imaging science professional must obtain a detailed patient history to give appropriate patient care. Patient history factors in barium sulfate examinations and their importance. H. Ability to communicate, hear, and follow directions. Risk for colon perforation caused by loss of tissue tone. Diverticulitis or ulcerative colitis. Difficulty in holding an enema, risk for colon perforation. Long-term steroid therapy. Risk for colon perforation. Colon biopsy within previous 2 weeks. Lower gastrointestinal series contraindicated. Pregnancy. Inform radiologist before proceeding with examination. Mental retardation, confusion, or dizziness. Risk for aspiration during upper gastrointestinal series. Recent onset of constipation or diarrhea. Risk for colon perforation or tumor rupture. Nausea and vomiting. Risk for aspiration during upper gastrointestinal series. Common procedures for which barium sulfate suspensions are used: area, concentration, method of administration, patient preparation, and patient care and information during procedure. Esophagus, esophagram. 30 to 50 concentrations administered orally. No preparation. Provide supportive communication. For esophageal varices, the patient should exhale, swallow barium, and then hold their breath on that exhalation for that exposure. Stomach, upper gastrointestinal series. 30 to 50 concentration administered orally. Nothing to eat or drink after midnight before examination. Provide supportive communication. Provide explanation of reasons for various positions. Small intestine, small bowel series. 40 to 60 concentrations if included with stomach examination administered orally. If included with a stomach examination, low residue diet eaten for 2 days before examination. Provide supportive communication. Provide explanation for length of procedure. In most patients, the transit time of the barium sulfate suspension through the small intestine is approximately 1 hour. Large intestine, colon or barium enema. 12 to 25 concentrations administered rectally. Large amount of fluid or fluid diet day before examination. Nothing to eat or drink after midnight before examination. Cleansing enema before examination. Provide supportive communication so that the patient does not lose control. Watch patient for changes in mental status that may indicate fluid overload. Stomach, computed tomographia. 12 to 25 concentrations administered orally. Nothing to eat or drink after midnight before examination. Provide supportive communication. The patient should believe that the radiographer is constantly watching the procedure. Adverse reactions. As previously mentioned, patients should be instructed to drink plenty of fluids after receiving barium sulfate. All barium sulfate suspensions transit the colon. Because one function of the colon is to absorb water from waste, barium sulfate residue within the colon can dry and cause an obstruction. The major symptom of obstruction is constipation. A complication related to the administration of barium sulfate during a lower GI examination is perforation of the colon with extravasation, leakage through a duct or vessel, into the abdominal cavity. Extravasation results in inflammation of the abdominal cavity, termed barium peritonitis. Older adult patients or persons receiving long-term steroid medication are at increased risk for colon perforation because their tissues have become atrophic, lost elasticity and muscle tone. Also at risk are patients with diverticulitis and ulcerative colitis because these diseases result in inflammation and degradation of the colon tissues. Patients with toxic megacolon should not have lower GI procedures because this serious complication of ulcerative colitis results in a dilated colon that can rupture. Recent biopsy of the colon is a contraindication to a lower GI series until the area heals. The barium retention catheter can be a source of colon perforation. The radiographer should use 1 or 2 gentle squeezes, or 1 full squeeze, to inflate the retention cuff. Consult with the physician in charge for best practices. Vaginal rupture, a rare complication of barium sulfate administration, is caused by incorrect placement of the catheter before lower GI examinations. Knowing the anatomy of the female pelvis in the anteroposterior and lateral configurations is critical. Female patients should be asked whether they can feel the enema tip in the rectum. Water absorption from the colon is a serious complication of lower GI administration of barium sulfate suspensions. Water from the cleansing enema and the barium enema can be shifted from the colon into the circulatory system with a resulting increase in blood volume. Consequences of this fluid overload are pulmonary edema, fluid in the lungs, seizures, coma, and death. The table salt solution previously discussed reduces the possibility of hypervolemia. The radiologic and imaging science professional must observe patients for changes in mental status, such as apathy and drowsiness, that would indicate onset of hypervolemia. Symptoms of fluid overload are masked in sedated patients, therefore, sedative pre-medication is contraindicated for lower GI examinations. Sedated patients should not undergo upper GI examinations because the swallowing reflex is diminished, which greatly increases the risk for aspiration, inhalation, of the barium sulfate suspension with resultant barium pneumonia. Aspiration is also a risk for mentally handicapped patients and persons with altered mental status because of age or disease. A few allergic type reactions have been noted, but these may have been caused by preservatives in the particular barium sulfate preparation or by latex used in barium enema retention catheters. Occasionally, barium sulfate has collected within the appendix. No directly related complications have resulted from this occurrence. Water-soluble iodine contrast media. Physical properties. Ionic iodine contrast media. The element iodine has an atomic number of 53, making it relatively radiopaque. Ionic media dissociate into 2 molecular particles in water or blood plasma, just as table salt does. These media are ionic because one particle, called an anion, has a negative charge and the other particle, called a cation, has a positive charge. The anion part of the molecule begins with a 6-carbon bonded hexagon called benzene. A carbon atom is located at each corner of the hexagon but is not usually drawn because the molecular diagram would appear cluttered. Every other carbon bond site of the benzene is bonded to an iodine atom, therefore, each anion portion contains 3 iodine atoms and is therefore triiodinated. Of the 3 remaining carbon bond sites, 1 is occupied by an acid group. The acid group carries the negative charge at physiologic pH. At the acid group, the anion and cation dissociate on injection. The other 2 carbon bond sites are occupied by chemical structures that increase the solubility or the excretion rate of the contrast by the body. These 2 carbon bond sites result in the different classes of ionic media, diatrizoate, metrizoate, and iethylamate. The cation part of the molecule is either a sodium atom or a more complex structure, Methylglucamine. Its rather long name describes its structure. The 6 carbons bonded to one another in a straight line and bonded to oxygens and hydrogens, hydroxyl groups, come from glucose, a common biologic sugar. The hydroxyl groups increase solubility. The nitrogen on the left is part of an amine group. Amines are found in amino acids, and ammonia contains nitrogen. Finally, a 1-carbon, 3-hydrogen group is attached to a nitrogen on the left. These 1-carbon, 3-hydrogen methyl groups are extremely common. Methylglucamine is sometimes identified as meglumin on package inserts. Most ionic iodine contrast media are identified as higher osmolality contrast media because of their osmotic effects. Osmolality is a measure of the total number of particles in solution per kilogram of water. The osmolality of contrast media is of great biologic significance. Most adverse reactions to contrast media have been related to the osmolality of the media because the osmolality of a solution determines osmotic pressure, which controls the movement of water in the body. High osmolality contrast media have an increased number of particles in solution, such as blood plasma, which pull water toward them. Non-ionic iodine contrast media. Efforts to decrease the many side effects of ionic iodine contrast media resulted in the development of molecules that do not dissociate into anions and cations, non-ionics, or that are ionic but too big to have osmotic effects, such as ioxyglat, hexabrix. These agents are identified as lower osmolality contrast media. Ioxyglat is an ionic molecule composed of 2 connected benzene hexagons, one that carries an acid group that dissociates on injection. This contrast agent is a dimer because it is composed of 2 identical simpler molecules. Ioxyglat carries 6 iodine atoms per molecule. It is ionic because it dissociates into 2 particles in blood plasma. Most ionic iodine contrast media are monomers, or simple molecules of relatively low molecular weight. Because dimers are large molecules, their osmotic effects are low. Because of their high molecular weights, they are viscous. Recently, a non-ionic dimer, iodizanol, Visopaque, was introduced. Iodizanol is made to be isomolar, having the same number of particles, to blood plasma by the addition of electrolytes, small anions, and cations, which are normally present in blood plasma. An additional advantage of the lower osmolality contrast media is that they are more hydrophilic, water-soluble, than the higher osmolality contrast media. As a result, they may be less likely to be reactive with the cells that can trigger allergic effects. The molecular structure of one of the water-soluble non-ionic iodine contrast agents, ioversol, Optire, is a triiodinated benzene ring and does not carry an acid group. Many oxygen-hydrogen hydroxyl groups surround the benzene ring. These groups increase the solubility of the media in blood plasma. Iodine in its elemental form is chemically reactive and can be toxic in the body. Consequently, both ionic and non-ionic agents contain additives such as citrate and calcium disodium edetate. These compounds prevent iodine atoms from being removed from the contrast molecules. General effects. Water-soluble iodine contrast media have known physiologic effects. High osmolality and the aspects of chemical structure are the major characteristics of the water-soluble media that are responsible for these effects. Although both ionic and non-ionic iodine media have physiologic effects on the body, most ionic agents are higher osmolality contrast media and therefore have shown greater effects and adverse reactions. Viscosity, or friction, of a medium is influenced by the concentration and size of the molecule. It affects the injectability, or delivery, of the medium. Heating the medium to body temperature significantly reduces the viscosity and facilitates the ability for rapid injection. Heating is commonly accomplished through the use of a contrast warmer. Osmotic effects. Because ionic media dissociate in water, their injection into the blood plasma results in a great increase in the number of particles present in the plasma, which has the effect of displacing water. Water moves from an area of high concentration to an area of low concentration. The process is called osmosis. When the plasma water is displaced by contrast particles, water from body cells moves into the vascular system. This movement results in hypervolemia and blood vessel dilatation, producing pain and discomfort. Blood pressure may decrease because of vessel dilatation, or it may increase as a result of hypervolemia and the effects of hormones in the kidneys. When higher osmolality contrast media are given for imaging of the intestinal tract, fluid from cells is drawn into these areas. This osmotic effect can aid in reducing obstructions because the increase in fluid increases peristalsis. In dehydrated patients, however, the osmotic effect further reduces body cell volume and can result in shock. Consequently, Obtaining a patient history and conveying any contraindications to the radiologist or other physician are important. The number of molecular particles of a particular contrast medium is shown on the package insert in units of milliosmoles per kilogram of water at 37 degrees Celsius. The higher the number is, the greater will be the number of particles that can produce osmotic effects. As an example, the osmolality of iodizanol at 300 mg of iodine per milliliter in milliosmoles per kilogram is 290, equal to that of blood plasma. Allergic-like effects, anaphylactoid. Allergic reactions to water-soluble iodinated contrast media resemble allergic reactions to foreign substances, such as pollen grains. Reactions of typical allergic patients may be minor, such as urticaria, hives. Some patients, however, experience wheezing and edema in the throat and lungs, with accompanying bronchospasm. Other anaphylactoid effects of water-soluble iodinated contrast media are nausea and vomiting. These reactions are thought to be caused by the release of a substance called histamine from certain cells found in the lungs, stomach, and lining of blood vessels. Although some radiologists believe that the allergic-like effects are caused by extreme anxiety, the radiologic and imaging science professional should consider these effects as serious. Pre-medication with steroids and antihistamines, to prevent the release of histamine, can reduce or eliminate allergic effects. Renal effects. High osmolality contrast media can cause the arteries of the kidneys to expand as a result of the osmotic effect. Arterial expansion results in the release of vasoconstrictors. These substances cause constriction of the renal arteries. Therefore, injection of the contrast media results in dilatation and then constriction of the renal arteries. The end result is diminished blood supply to the kidneys. Osmotic effects are also presumed to cause an increase in the number of molecular substances that cannot be reabsorbed by the renal tubules. This increase results in osmotic diuresis, increased secretion of urine, and dehydration. Increased blood urea nitrogen, BUN, and creatinine, waste product of metabolism, levels indicate that the patient may have renal disease and are good indicators for possible contrast medium-induced renal effects. Patients with renal disease or diabetes and older patients are at increased risk for these complications. Intravenous fluid given before and during procedures can reduce the severity of renal effects. Theophylline, a substance found in tea, is currently being investigated as a preventive of toxic renal effects by increasing the filtering action of the kidneys. Other effects. Carotid artery injection of water-soluble iodine contrast media can alter the blood-brain barrier, separation between brain capillaries and support cells for the neurons, by causing the capillary cells to shrivel because of water loss. Some of these media can stimulate areas in the carotid artery that help control heart rate and blood pressure. Clinical symptoms of these effects include increased blood pressure, bradycardia, slow heartbeat, and tachycardia, fast heartbeat. In patients with sickle cell anemia and those who carry the trait but who are asymptomatic, injection of high osmolality contrast media can cause the red blood cells to shrink and to sickle, assume an elongated shape. These sickled cells may be trapped in small diameter blood vessels and capillaries, causing pain and blood clots. A common effect is a sensation of warmth and pain on injection into the arterial vessels. Theories suggest that this effect is caused by dissociation of the contrast media into anions and cations. In helical computed tomography, CT, procedures, a large amount of contrast material is injected at a rate of at least 2.5 milliliters per second. This amount increases the probability of nausea and vomiting and extravasation of the contrast with patient motion as a result. Drug interactions and considerations. One class of drugs used to treat hypertension is the beta-adrenergic blockers. These drugs reduce cardiac output, but they also reduce dilatation of bronchial smooth muscle and block the effect of epinephrine. Patients who take these drugs are at increased risk for anaphylactoid reactions during procedures in which water-soluble iodine contrast media are used. Calcium channel blockers reduce hypertension by relaxing electrical conduction of cell membranes in arterioles, small arteries, and in heart muscle. Patients who take these drugs are at risk for heart block and abrupt decrease in blood pressure if ionic contrast media are used during cardiac catheterization. Metformin, glucophage, is a type of drug used to treat non-insulin-dependent diabetes. Metformin should be discontinued for 48 hours before and 48 hours after the use of iodine contrast media. Although metformin does not interact with the iodine contrast agents, if renal failure should occur as an effect of iodine contrast administration, drug levels of metformin would accumulate in the patient and lactic acidosis might develop. Metformin increases the uptake of glucose in body cells. One end product of glucose metabolism is lactic acid. Consequently, increased levels of metformin will increase lactic acid production and decrease the pH in body cells, acidosis. Considerations in the use of non-ionic contrast media. Most adverse reactions associated with water-soluble ionic iodine contrast media are significantly decreased with the use of the non-ionic media. This decrease is attributed to the decreased osmolality of the non-ionic media. In addition, the injection of non-ionic contrast media during angiography is much less painful compared with injection of ionic media. However, kidney toxicity has not been reduced. Including the patient's BUN and creatinine level in the history is therefore important. Non-ionic iodine contrast media cost 2 to 3 times more than ionic media. Therefore, decisions about which patients will receive non-ionic media are controversial. Some institutions have decided to use low osmolality contrast media on all patients regardless of cost. Other institutions have established a selective use of these agents. Sample criteria for the use of low osmolality, non-ionic, contrast media might include the following. Patients with a history of adverse reactions to contrast media, excluding mild reactions such as the sensation of heat or flushing. Patients with a history of asthma or allergies. Patients with known cardiac problems. Patients with generalized severe debilitating conditions. Patients who will undergo helical CT procedures. These criteria include patients with diabetes mellitus, renal disease, or elevated creatinine levels, or sickle cell disease. Specific procedures. A wide variety of radiologic and imaging science procedures use water-soluble iodine contrast media. These agents are important in visualizing the urinary and cardiovascular systems in particular. They are also commonly used in CT studies of the brain, chest, and abdomen. Some procedures for which water-soluble iodine contrast media are used: area, contrast agent, administration, patient prep, and patient instructions and care. Brain. Cerebral angiography, computed tomography. Usually non-ionic contrast agent. Injection into vein or artery, usually liquid diet to minimize nausea. Pre-medication for sedation. Intravenous fluids to aid hydration. Provide supportive communication. Tell the patient that they may feel warm and sense a metallic taste on injection. Explain what is being done as it is being done. Watch the patient for adverse reactions. Apply pressure to injection site after procedure is completed. Thorax. Thoracic angiography or 4-vessel study. Usually non-ionic agent. Injection into vein or artery, usually liquid diet to minimize nausea. Pre-medication for sedation. Intravenous fluids to aid hydration. Provide supportive communication. Tell the patient that they may feel warmth and sense a metallic taste on injection. Explain what is being done as it is being done. Watch the patient for adverse reactions. Apply pressure to injection site after procedure is completed. Lower limbs. Venography. Usually non-ionic contrast agents. Injection into vein. Sometimes pre-medication for sedation. Intravenous fluids for hydration. Provide supportive communication. Tell the patient that they may feel warmth and sense a metallic taste on injection. Explain what is being done as it is being done. Some pain may be present. Watch the patient for adverse reactions. Apply pressure to injection site after procedure is completed. Spinal canal. Myelography. Only non-ionic contrast agents administered by injection into subarachnoid space. Usually a liquid diet prefaces this procedure, and also usually pre-medication for sedation. Provide supportive communication. Explain the use of shoulder braces and that the table will be tilted but the patient's head must be kept in extension. Explain what is being done as it is being done. Watch the patient for adverse reactions. Advise nursing staff and patients that the patient should remain in bed with the head up for 24 hours to prevent headache and nausea. Kidneys, ureters, and bladder. Excretory urography, renal angiography, cystography. Usually non-ionic agents are used. Injected into a vein or artery. For cystography, usually through a catheter in urinary bladder. Liquid diet day before examination to reduce gas formation. Laxatives or a cleansing enema may be given. Bladder should be emptied before the examination begins. Provide supportive communication. Tell the patient that they may feel warmth and sense a metallic taste during and just after injections. Several injections may be performed. Explain the timing of the radiographs and the X-ray tube movement if tomography is done. Watch the patient for adverse reactions. Angiography. Apply pressure to the injection site after procedure is completed. Heart and coronary arteries. Cardiac catheterization. Usually uses non-ionic agents, administered typically through a catheter. Liquid or low-residue diet is usually ordered the evening before the procedure. Antibiotics are usually ordered. Premedicate for sedation. Intravenous fluids utilized for hydration. Blood clotting, prothrombin, time must be within a range acceptable to the physician. Catheter may be inserted in a femoral artery, therefore, strength of dorsal pedal pulses is evaluated. Provide supportive communication. Tell the patient that they may feel warmth and sense a metallic taste on injection. Explain what is being done as it is being done. The patient may be apprehensive about the movements of the X-ray tube around the body or the use of 2 X-ray tubes. Lead glass shielding should be explained. Nursing procedures, monitoring of peripheral pulses and blood pressure. Watch the patient for adverse reactions. Advise nursing staff that temperature may be elevated after procedure. The most important patient care aspect before administration of water-soluble iodine contrast media is the patient history. The possibility of patient reaction is closely related to the patient's disease state or age. Moreover, the chemical nature of these contrast media can provoke severe reactions. The radiologic and imaging science professional is responsible for observation of patient well-being. Patient history factors in water-soluble iodine contrast examinations and their importance. Age. Risk with increased age. Allergies or asthma. Risk for allergic-like reactions. Diabetes. Insulin usually given before procedure, these patients should be scheduled before others. Coronary artery disease. Risk for tachycardia, bradycardia, hypertension, myocardial infarction, heart attack. Hypertension with tachycardia. Renal disease, inform radiologist if creatinine level is above 1.4 mg dl. Multiple myeloma. Abnormal protein binds with contrast and can cause renal failure. Patients must be hydrated. Confusion or dizziness. Blood-brain barrier effects. Sickle cell anemia or family history of chronic obstructive pulmonary disease. Risk for blood clots, risk for dyspnea, difficulty in breathing. Previous iodine contrast examinations. Did the patient have difficulties with the procedure? Pregnancy. Inform radiologists before proceeding. History of blood clots. Risk for blood clots. Use of beta blockers. Risk for anaphylactoid reactions. Use of calcium channel blockers. Risk for heart block. Use of metformin, glucophage. Risk for lactic acidosis if renal failure occurs. Adverse reactions. As discussed in the section on the general effects of water-soluble iodine contrast media, these media have physiologic effects that may result in adverse reactions. The responsibility of the radiologic and imaging science professional in patient surveillance is critical in assessing the severity of these effects. Categories of acute reactions to contrast media: mild, moderate, and severe allergic reactions, their physiological consequences and their treatment. Mild. Signs and symptoms are self-limited without evidence of progression. Mild reactions include limited urticaria pruritus, limited cutaneous edema, limited itchy scratchy throat, nasal congestion, sneezing conjunctivitis rhinorrhea, limited nausea vomiting, transient flushing warmth chills, headache dizziness anxiety altered taste, mild hypertension, vasovagal reaction that resolves spontaneously. Treatment requires observation to confirm resolution and or lack of progression but usually no treatment. Patient reassurance is usually helpful. Moderate. Signs and symptoms are more pronounced and commonly require medical management. Some of these reactions have the potential to become severe if not treated. Moderate reactions include diffuse urticaria pruritus, diffuse erythema, stable vital signs, facial edema without dyspnea, throat tightness or hoarseness without dyspnea, wheezing bronchospasm, mild or no hypoxia, protracted nausea vomiting, hypertensive urgency, isolated chest pain, vasovagal reaction that requires and is responsive to treatment. Clinical findings in moderate reactions frequently require prompt treatment. These situations require close, careful observation for possible progression to a life-threatening event. Severe. Signs and symptoms are often life-threatening and can result in permanent morbidity or death if not managed appropriately. Cardiopulmonary arrest is a nonspecific end-stage result that can be caused by a variety of the following severe reactions, both allergic-like and physiologic. If it is unclear what caused the cardiopulmonary arrest, it may be judicious to assume that the reaction was an allergic-like one. Pulmonary edema is a rare severe reaction that can occur in patients with tenuous cardiac reserve, cardiogenic pulmonary edema, or in patients with normal cardiac function, non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema can be allergic-like or physiologic. If the cause is unclear, it may be judicious to assume that the reaction was an allergic-like one. Severe reactions include diffuse edema, or facial edema with dyspnea, diffuse erythema with hypotension, laryngeal edema with stridor and or hypoxia, wheezing bronchospasm, significant hypoxia, anaphylactic shock, hypotension plus tachycardia, vasovagal reaction resistant to treatment, arrhythmia, convulsions, seizures, hypertensive emergency. Requires prompt recognition and aggressive treatment. Manifestations and treatment frequently necessitate hospitalization. Management of acute reactions in adults, treatment and dosage. Hives. Mild, scattered and or transient, no treatment often needed, however, if symptomatic, can consider diphenhydramine, Benadryl, a 25 to 50 mg PO, or fexofenadine, Allegra, B 180 mg PO. Moderate, more numerous bothersome. Monitor vitals. Preserve IV access. Consider diphenhydramine, Benadryl, a 25 to 50 mg PO or fexofenadine, Allegra, B 180 mg PO or consider diphenhydramine, Benadryl, a 25 to 50 mg IM or IV, administer IV dose slowly over 1 to 2 minutes. Severe, widespread and or progressive. Monitor vitals. Preserve IV access. Consider diphenhydramine, Benadryl, a 25 to 50 mg IM or IV, administer IV dose slowly over 1 to 2 minutes. Can also consider epinephrine, IM 0.3 mg, 0.3 ml of 1 to 1000 dilution, or IM EpiPen or equivalent, 0.3 ml of 1 to 1000 dilution, fixed, or epinephrine, IV 1 to 3 ml of 1 to 10,000 dilution, administer slowly into a running IV infusion of saline. Diffuse erythema. All forms. Preserve for access. Monitor vitals. Pulse oximeter. O2 by mask, 6 to 10 liters per minute. Normotensive. No other treatment usually needed. Hypotensive. IV fluids 0.9% normal saline, 1000 milliliters administered rapidly, or lactated Ringer solution, 1000 milliliters rapidly. If profound or unresponsive to fluids alone, one can also consider epinephrine, IV 1 to 3 milliliters of 1 to 10,000 dilution, administer slowly into a running IV infusion of saline, can repeat every few minutes as needed up to 10 milliliters, 1 milligram, total, or, if no IV access available, epinephrine, IM 0.3 milligrams, 0.3 ml of 1 to 1000 dilution, can repeat up to 1 milligram total, or IM EpiPen or equivalent, 0.3 ml of 1 to 1000 dilution, fixed, can repeat every 5 to 15 minutes up to 3 times. Consider calling emergency response team or 911. Bronchospasm. All forms. Preserve IV access. Monitor vitals. Pulse oximeter. O2 by mask, 6 to 10 liters per minute. Mild. Beta agonist inhaler, albuterol. 2 puffs, 90 mcg puff, for a total of 180 mcg, can repeat up to 3 times. Consider sending a patient to emergency department or calling emergency response team or 911, based on the completeness of the response. Moderate. Consider adding epinephrine, IM 0.3 milligrams, 0.3 ml of 1 to 1000 dilution, administer slowly into a running IV infusion of saline, can repeat every 5 to 15 minutes up to 1 ml, 1 milligram, total, or consider sending patient to emergency department or calling emergency response team or 911, based on the completeness of the response. IM EpiPen or equivalent 0.3 ml of 1 to 1000 dilution, fixed, 0.3 milligrams, can repeat every 5 to 15 minutes up to 3 times, or epinephrine, IV 1 ml of 1 to 10,000 dilution, 0.1 milligrams, administer slowly into a running IV infusion of fluids or use saline flush, can repeat every few minutes as needed up to 10 ml, 1 milligram, total. Severe. Epinephrine IVC. IV 1 ml of 1 to 10,000 dilution, 0.1 milligrams, administer slowly into a running IV infusion of fluids or slow IV push followed by a slow saline flush, can repeat every few minutes as needed up to 10 ml, 1 mg, total, or epinephrine IMC, IM 0.3 mg, 0.3 ml of 1 to 1000 dilution, can repeat every 5 to 15 minutes up to 1 ml, 1 mg, total, and or beta agonist inhaler, albuterol, may work synergistically, 2 puffs, 90 mcg puff, for a total of 180 mcg, can repeat up to 3 times. IM EpiPen or equivalent, 0.3 ml of 1 to 1000 dilution, fixed, can repeat every 5 to 15 minutes up to 3 times. Call emergency response team or 911. Laryngeal edema. All forms. Preserve IV access. Monitor vitals. Pulse oximeter. O2 by mask, 6 to 10 liters per minute. Epinephrine, IV, C, IV 1 to 3 ml of 1 to 10,000 dilution, administer slowly into a running IV infusion of saline, can repeat every few minutes as needed up to 1 mg total, or epinephrine, IM, C, IM 0.3 mg, 0.3 ml of 1 to 1000 dilution, can repeat every 5 to 15 minutes up to 1 mg total, or IM EpiPen or equivalent, 0.3 ml of 1 to 1000 dilution, fixed, can repeat every 5 to 15 minutes up to 3 times. Consider calling emergency response team or 911 based on the severity of the reaction and the completeness of the response. Hypotension, systolic blood pressure less than 90 mm Hg. Preserve IV access. Monitor vital signs. Pulse oximeter. O2 by mask, 6 to 10 liters per minute. Elevate legs at least 60 degrees. Consider IV fluids, 0.9% normal saline, 1000 ml administered rapidly, or lactated Ringer solution, 1000 ml rapidly. Hypotension with bradycardia, pulse less than 60 bpm, vasovagal reaction. Mild. No other treatment usually necessary. Severe, patient remains symptomatic despite above measures. In addition to above measures, IV atropine, 0.6 to 1 mg, administer slowly, followed by saline flush, can repeat up to 3 mg total. Consider calling emergency response team or 911. Hypotension with tachycardia, pulse greater than 100 beats per minute, anaphylactoid reaction. If hypotension persists, epinephrine IVC, IV 1 to 3 ml of 1 to 10,000 dilution, administer slowly in a running IV infusion of saline, can repeat every few minutes up to 1 mg total, or epinephrine IMC, IM 0.3, 0.3 of 1 to 1000 dilution, can repeat every 5 to 15 minutes up to 1 mg total, or IM EpiPen or equivalent, 0.3 ml of 1 to 1000 dilution, fixed, can repeat every 5 to 15 minutes up to 3 times. Consider calling emergency response team or 911 based on the severity of the reaction and the completeness of the response. Hypertensive crisis, diastolic blood pressure greater than 120 mm Hg, systolic blood pressure greater than 200 mm Hg, symptoms of end organ compromise. All forms. Preserve IV access. Monitor vital signs. Pulse oximeter. O2 by mask, 6 to 10 liters per minute. Labetalol, IV, IV 20 mg, administer slowly over 2 minutes, can double the dose every 10 minutes, for example, 40 mg 10 minutes later, 80 mg 10 minutes after that, or if labetalol is not available, nitroglycerin tablet, SL, 0.4 mg tablet, can repeat every 5 to 10 minutes, and furosemide, Lasix, IV, IV 20 to 40 mg, administer slowly over 2 minutes. Call emergency response team or 911. Unresponsive and pulseless. Check for responsiveness. Activate emergency response team, call 911. Chest compressions at the rate of 100 to 120 per minute, then 2 respirations. Get defibrillator or automated electronic defibrillator, AED, apply as soon as available, shock as indicated. Epinephrine, between 2-minute cycles, IV 10 ml of 1 to 10,000 dilution, administer entire ampoule quickly. Pulmonary edema. Preserve IV access. Monitor vital signs. Pulse oximeter. O2 by mask 6 to 10 liters per minute. Elevate head of bed if possible. Furosemide, Lasix, IV 20 to 40 mg, administer slowly for 2 minutes. Morphine, IV, IV 1 to 3 mg, repeat every 5 to 10 minutes, as needed. Call emergency response team or 911. Seizures. Observe and protect the patient. Turn patient on side to avoid aspiration. Suction airway as needed. Preserve IV access. Monitor vitals. Pulse oximeter. O2 by mask 6 to 10 liters per minute. If unremitting, call emergency. Lorazepam, IV, IV 2 to 4 mg, administer slowly, to maximum dose of 4 mg. Call emergency response team or 911. Hypoglycemia. Preserve 4 access. O2 by mask, 6 to 10 liters per minute. If patient is able to swallow safely, oral glucose, 2 sugar packets or 15 g of glucose tablet or gel or 1/2 cup, 4 ounces, of fruit juice or any sugary soda. If patient is unable to swallow safely and IV access is available, administer dextrose 50%, IV, IVD 50W, 1 ampoule, 25 g, administer over 2 minutes. D5W or D5NS, IV, as adjunct therapy. Administer at a rate of 100 ml per hour. If no IV access is available, use glucagon, IM 1 mg. Anxiety, panic attack. Diagnosis of exclusion. Assess patient for developing signs and symptoms that might indicate another type of reaction. Preserve IV access. Monitor vital signs. Pulse oximeter. If no identifiable manifestations and normal oxygenation, consider this diagnosis. Reassure patient. Reaction rebound prevention. Note, although IV corticosteroids may help prevent a short-term recurrence of an allergic-like reaction, they are not useful in the acute treatment of any reaction. However, these may be considered for patients having severe allergic-like manifestations before transportation to an emergency department or inpatient unit. Hydrocortisone, Solacort-F, IV, 4-5 mg per kilogram, administer over 1 to 2 minutes, or methylprednisolone, Solomidrol, IV, 5 mg per kilogram, administer over 1 to 2 minutes. Contrast media in children. Some considerations need to be made when working with children and contrast media. Although many principles are the same as for adults, there are some differences to consider. If pediatric cases are rare in your facility, you may want to contact a children's hospital for recommendations and guidance. Contrast media osmolality is of particular importance in neonates and small children. These patients can be especially susceptible to fluid shifts that could in extreme cases lead to cardiac failure and pulmonary edema. In children who have significant pre-existing conditions such as cardiac dysfunction, consideration should be given to use isoosmolality intravascular contrast agents. Another consideration is contrast media viscosity with pediatric patients. If a rapid injection rate is desired through a small angio catheter with a high viscosity agent, 2 issues could occur. The proper injection rate may not be possible, and the catheter could burst, causing vessel injury in the pediatric patient. Other common issues with pediatric patients and contrast agent use include small volumes used, small gauge angio catheters, and unusual vascular access sites. Care should also be used because children may not effectively communicate pain at the injection site if a dose extravasation occurs. Radiopharmaceuticals. General characteristics. A radiopharmaceutical is not a contrast agent. A radiopharmaceutical is a radionuclide that is attached, chemically bound, to a pharmaceutical that has a specific biodistribution in the human body. This biodistribution depends on many factors, such as route of administration, gas, liquid, or solid state of the radiopharmaceutical, and sensitivity, as well as specificity, of the pharmaceutical in the body as it is taken up. The radioisotope attached to the pharmaceutical is imaged using a gamma camera, which sees or detects where the radiopharmaceutical is in the body and forms an image of more or less concentration of the radiopharmaceutical. Physicians read the images knowing the normal biodistribution patterns and look for pathologic conditions within the body based on where the radiopharmaceuticals concentrate. The functionality of this procedure lies in the ability of many radiopharmaceuticals to be taken up by an organ of interest and then be metabolized and used or eliminated by the body. A prime example would be renal imaging, whereby the radiopharmaceutical is taken up by the kidneys, metabolized into urine, and collected in the bladder. If a patient has a kidney stone that is blocking the path of urine in one of the ureters, this stone would show up while the study is being performed. Physicians can also determine the rate of uptake and elimination of the radiopharmaceutical in the kidneys and determine if they are functioning normally or not. This method is how an effective renal plasma flow is determined. Selected radiopharmaceuticals, their radionuclide, name, main energy, half-life, and target organs. 99 mTC. Midronate. 140 keV 6.02 hours. Bone. 99 mtc. Merciatide. 140 cav 6.02 hours. Kidneys. 99 mtc. Sulfur colloid. 140 cav 6.02 hours. Liver, spleen. 99 mtc. Mebrofenin. 140 cav 6.02 hours. Hepatobiliary. 99 mtc. Albumin aggregated. 140 cav 6.02 hours. Lung perfusion. 99 mtc. Tetrophosmin. 140 cav 6.02 hours. Myocardial perfusion. 99 mtc. Phenolizumab. 140 cav 6.02 hours. Appendix. 201 TL thalaus chloride. 68 to 80 cav 3.04 days. Myocardial perfusion. 131 isodium iodide. 364 cav gamma beta used for therapy. 8.02 days. Thyroid imaging or therapy ablation. 67 Ga citrate. 93,184, 300, or 393 cav 3.26 days. Infection, inflammation. 133 Xe. Xenon gas. 81 cav 5.243 days. Lung ventilation. Positron emission tomography agents. A positron is a positive electron, which is also known as antimatter. Antimatter cannot exist for long because when it comes into contact with a negative electron, it annihilates itself into two 511 keV photons of energy that are approximately 180 degrees apart from each other. Positron emission tomography, PET, imaging takes advantage of these two 511 keV photons nearly 180 degrees opposite each other to do coincidence imaging, whereby the gamma camera accepts only two 180-degree opposing events to form an image. Positron emitters are formed in a cyclotron and often have very short half-lives. When using contrast media for a PET CT scan for a diagnostic CT, one should do the PET study first and then the CT examination. There is a small possibility that the contrast media could attenuate or interfere with the PET scan if the area of interest is a place in the body that concentrates the contrast media. Selected positron emission tomography agents, their radionuclide, name, main energy, half-life, and target organs. 18F-fluorodeoxyglucose. 511 cav 109.71 minutes. Brain, heart, tumors. 11C roclopride. 511 cav 20.3 minutes. Neurologic and psychiatric disorders, Parkinson's disease. 15O saline. 511 cav 122 seconds. Myocardial and cerebral perfusion. 13N acidic saline. 511 cav 9.97 minutes. Myocardial and cerebral perfusion. Special considerations when working with unsealed radiation sources. The primary concern when working with short-lived, small half-lives of hours, minutes, or seconds, unsealed radiation sources is contamination, which can occur on patients, personnel, floors, tables, or imaging equipment, that might be misconstrued as part of the image produced for physicians to read. These artifacts may not be easily ascertained and might be misinterpreted by a physician as a pathologic abnormality in a patient when reading a study. Another concern with contamination of unsealed sources is increased radiation exposure to personnel and patients that might occur. This contamination might be in the form of external or internal contamination. External contamination would be dropped, splashed, or spilled unsealed sources deposited on someone or something. Internal contamination might occur if these dropped, splashed, or spilled unsealed sources were internalized via inhalation, absorption, or ingestion. Unsealed sources must be contained as much as possible before, during, and after their use. This contamination is why nuclear medicine personnel recap needles on a syringe or otherwise secure the needle and syringe after use, whereas all other medical personnel do not. Magnetic resonance contrast media agents. There are several commercially available MRI contrast media on the market. Examples and their uses include Omniscan, used to primarily help diagnose certain disorders of the brain. Eovist, used to primarily diagnose disorders of the liver. Gatavist, used mainly for magnetic resonance angiographies, MRAs, to allow blood vessels, organs, and other non-bony tissues to be seen more clearly. Magnevist, used to see blood vessels, organs, and non-bony tissues more clearly. Ablavar, this contrast raises the chance of the health problem NSF, nephrogenic systemic fibrosis, or NSF, in some people. This may lead to very bad and sometimes deadly skin, muscle, and organ problems. Deuterium raises the chance of health problem NSF, same as the contrast agent mentioned above. Faradex. This is the only MRI contrast agent that can be used while breastfeeding. Gastomark. This an oral suspension contrast used to visualize the stomach, small bowel, and large intestines. Multihance. This contrast has the same properties as Ablavar and Deuterium. Optimark. This is used to diagnose certain disorders of the brain and spine, the entire central nervous system. Prohance. This contrast has the same properties as Ablavar, Deuterium, and Multihance. Teslascan. This contrast is used to provide a clear picture in the MRI machine itself. It uses magnets and computers to create images or pictures of certain areas inside the body. Vasovist. This is primarily used in MRA imaging and to help diagnose certain disorders of the heart. NSF or nephrogenic fibrosing dermopathy, NFD, is a rare and serious syndrome that involves fibrosis of skin, joints, eyes, and internal organs. The first cases were identified in 1997 and its cause is not fully understood. However, evidence suggests that NSF is associated with exposure to gadolinium-based MRI contrast agents being frequently used as contrast agents for MRI in patients with severe kidney failure. Symptoms can occur 6 months after a procedure. If patients are diagnosed with NSF due to the use of MRI contrast, these patients develop large areas of hardened skin with fibrotic nodules and plaques. NSF may also cause joint pain and limitation in range of motion. In its most severe form, NSF may cause severe systemic fibrosis affecting internal organs including the lungs, heart, and liver. Concerns associated with the possibility of NSF development requires proper patient history taking of any renal disease and sometimes requires a creatinine blood test to assess renal function. Gadolinium contrast agents have received some negative publicity due to evidence that it accumulates in brain tissue. However, to date there is no evidence of any clinically significant symptoms associated with this issue. It is concerning because it was assumed that it cleared the body with no accumulation. Further research and long-term studies are underway to investigate this phenomenon. Health professional responsibilities. Qualifications of personnel who handle contrast media. The supervising physician should be a licensed physician with the following qualifications. 1. Certification in radiology or radiation oncology by the American Board of Radiology, the American Osteopathic Board of Radiology, the Royal College of Physicians, or Surgeons of Canada. 2. A minimum of 6 months of documented formal dedicated training in the interpretation and formal reporting of general radiographs or, if the residency or fellowship did not include formal training in the interpretation and formal reporting of general radiographs, the ability to demonstrate sufficient knowledge of pharmacology, indications, contraindications, and safe administration and the ability to initiate treatment in the event of adverse reactions. 3. Familiarity with the various risk factors, pre-medication strategies, and pre-procedural screening. 4. Immediate availability to respond in the event of an adverse reaction. 5. Knowledge of appropriate alternate imaging methods. 6. Awareness of the signs and symptoms of adverse reactions and how to monitor the patient having a contrast reaction. The radiologic and imaging science professional is responsible for patient comfort throughout the duration of the procedure, as well as for being able to identify the signs and symptoms of adverse reactions and having adequate knowledge of how to treat any adverse reaction. Patient preparation. The general considerations for the patient have 2 aims: contrast media reaction prevention and preparedness in the event of an adverse reaction. The prevention of contrast media reactions depends on obtaining a thorough patient history that can indicate contrast media contraindications or an increased likelihood of adverse reactions. Patient pre-procedural preparations and instructions to include adequate hydration and appropriate pre-medication when indicated, and adequate knowledge regarding treatment and use of emergency equipment in cases of adverse reactions. Sources of information. In almost no other medical specialty do practitioners inject, or have the patient ingest, such large amounts of non-biologic substances over a short time as in radiology. Obviously, the chemical structures of these agents greatly influence the 1. Ability of the agents to enhance subject contrast, 2. Types of agents used for specific procedures, and 3. Reasons for adverse reactions that can occur in patients. The discussion presented in this chapter about the physical properties of contrast media aids in interpreting the package inserts. The technologist should look at the chemical structure presented and locate the common chemical groups discussed. Then the radiologic and imaging science professional can consider other information in the package inserts about specific procedures, doses, and adverse reactions. Technical representatives from pharmaceutical companies that supply contrast agents can also supply journal articles as important sources of information. Problems arising from specific contrast media examinations should be discussed with the radiologist. Valuable insights for effective patient care are gained in this manner. Patient care and surveillance. The setup for any contrast media procedure, patient positioning, and radiographic technique are important professional responsibilities. The patient must remain the focus of the procedure, however. The patient is usually anxious about the procedure and the reasons that made the procedure necessary. In many instances the patient has an empty stomach, therefore, they may be irritable. These feelings, combined with the reasons for the adverse reactions from contrast media, may result in an increased possibility of these reactions. Due to an increase in outpatient procedures that use water-soluble iodine contrast media, instances of adverse reactions occurring hours later have been reported. These reactions have been poorly communicated to radiologists because of a lack of patient knowledge. The radiographer might develop an instruction sheet about mild adverse reactions and discuss these issues with the patient after the procedure is complete but before the patient leaves. Such instructions might include calling the department, direct telephone number, if any of the following occurs within 24 hours, hives, flushing, chills, nasal stuffiness, swelling of the eyes or face, or wheezing. A calm, supportive manner on the part of the radiologic and imaging science professional is a necessity. Continued communication, with questions regarding patient comfort, allows observation of the patient's physical and emotional status. A professional demeanor can increase the well-being of the patient and thereby reduce the possibility of adverse reactions. Many procedures require patient preparation at home, such as enemas before lower GI procedures and fasting after midnight before some procedures. The diagnostic quality of procedures that require patient preparation is diminished by patient failure to follow instructions. Before beginning the examination, the radiologic and imaging science professional must ask the patient if they followed the instructions for it. Some patients comply with some but not all the instructions. Therefore, the radiologic and imaging science professional must also find out to what extent the patient complied. This information can usually be obtained by one question: what did you do at home to prepare for your X-ray today? If the patient forgets an aspect of the instructions, then the radiologic and imaging science professional should use prompts such as, "What about the pills, Mr. Jones?" Many referring physicians do not tell their patients what to expect during contrast media procedures. In addition, many people have only a rudimentary knowledge of body functions. Explaining to the patients, in simple terms, what will be done is the radiologic and imaging science professional's responsibility. The radiologic and imaging science professional must also convey to the patient a sense of being cared for and a sense of being safe during the procedure. These subjective qualities can be communicated by addressing the patient by name, example Mr. Jones, Mrs. Green, by using blankets or sheets for warmth and modesty, by using pillows when possible, and by asking questions such as, "Are you warm enough?" Many patients exhibit reduced anxiety if the radiologic and imaging science professional explains the procedure as it is performed. Finally, a universal form of supportive communication is touch. Summary. Radiographic contrast media are used to visualize areas within the body that otherwise might not be seen well. These agents are not drugs, however, they can affect the physiologic status of patients. Radiolucent contrast media transmit X-rays and are usually used with radiopaque contrast media to visualize the lumina of organs and joint spaces. Radiopaque contrast media absorb X-rays and are used to demonstrate the GI, biliary, urinary, circulatory, lymphatic, and respiratory systems. Most adverse reactions encountered by patients are associated with the use of radiopaque contrast agents. Serious complications from the administration of barium sulfate include hypervolemia and colon and vaginal rupture. Water-soluble iodine contrast agents can cause allergic-like effects and can increase the severity of sickle cell anemia, renal disease, and diabetes. The patient history obtained by the radiologic and imaging science professional gives information about pre-existing disease that can increase the possibility of some adverse reactions. Appropriate patient preparation and care can then be given to eliminate or decrease these adverse reactions. The radiologic and imaging science professional should be familiar with the general chemical structure of contrast media and the relationship of the structure to the formal and trade names of the particular medium. The radiologic and imaging science professional absolutely must relate the various media to examinations for which they are best suited. Knowledge of specific patient preparations and adverse reactions associated with each agent is imperative. The radiologic and imaging science professional should be aware that radiopharmaceuticals are not contrast agents, and they must be aware of the special considerations for using PET agents and any unsealed radiation sources in a nuclear medicine department. The manner in which patient care is given can decrease the possibility of adverse reactions and can increase the diagnostic quality of the examination by increasing patient cooperation.